All right, good morning, everyone. Thank you for having us today. We know that you could be sitting in the rain at Oak Hill, but you're here learning about quality improvement, and we appreciate that. So in the next hour or so, we're going to cover the case for process and quality improvement in healthcare. We're going to talk about how we do it, methodologies, models, and tools. And we'll go through some of the past projects that we've been involved in and discuss some of the lessons learned, as well as the pitfalls and barriers that we've encountered over time. And then we'll give you some tools to start your own projects as well. And of course, at the end, we'll have some time for questions too. So quality improvement in healthcare, why do we need it? Let's talk a little bit about the history of quality improvement in healthcare. Going back almost 25 years ago, a publication came out titled "To Err is Human." This was put out by the Institute of Medicine, and it highlighted the fact that there were almost 100,000 preventable deaths per year occurring in the healthcare system. And that really shocked the system. It surprised people. We were under the impression that we were providing the best care in the world, and it seemed inconceivable that there could be 100,000 avoidable deaths. And if you're familiar with the Institute for Healthcare Improvement, a few years later, about 5 years later in 2004, they launched the 100,000 Lives campaign. And that was a textbook process improvement initiative to save 100,000 lives by avoiding those preventable deaths. And they actually, in 18 months, their goal was 100,000 lives, and they achieved almost 123,000 lives, and ended up scaling that to 5 million lives in the next few years. So if you have doubts about whether quality improvement can work, that's a perfect example of when it can. A few years later, following up to Err is Human, the book Crossing the Quality Chasm was published. And that really identified the gap between the way that healthcare was currently being practiced and the current system that we had and the system that we'd like to have. And it outlined 6 aims for improvement that kind of focused what is needed in order to achieve the system that we want. And it really called for a system overhaul. So you'll hear us say a few times throughout this presentation that a system is designed for the results that it gets. So if you want to change the results, you have to change the system. So the aims for improvement are listed here. I want to specifically call out equity because it has been on the list since 2001. But of course, in the past few years, specifically since the pandemic, it's become very clear that we haven't addressed health inequities the way that we need to in order to, again, achieve that health system that we want. And there was a paper published last year by Derek Feely, former CEO of IHI, that was titled "There is no quality without equity." So really underscoring the idea that you can't truly do quality improvement work without keeping equity in mind. You're probably familiar with the triple aim, which was improving population health, improving the care experience, while also lowering costs. A few years after that, the quadruple aim, the 4th aim was added for reducing clinician burnout. And now the 5th aim is addressing health inequity. So let's dive a little bit deeper into these 6 aims. You probably are looking at the list and they probably make sense to you, but maybe you're thinking, how can I deliver speedy care while it's also safe? You can't always maximize each of these 6 aims, but keeping them in mind as you are pursuing process improvement projects is going to help you kind of optimize the benefit and make sure you're designing well-rounded interventions. Another thing that we talk about in quality improvement is reliability. So you may be familiar with high reliability healthcare systems. And again, this quote from Dr. Edward Deming, kind of the father of lean thinking, talking about how the system is designed to get the results that it gets. Reliability is essentially how much can you depend on your process to perform its intended function and get those results that you're hoping for. So there are 3 levels of reliability. The first is about 80 to 90% reliable. And it's interesting to note that a process that is only 80% reliable is actually considered to be in chaos. So These this level of reliability depends on education and training, marketing, communication. It's the type of thing when you're trying to change the behavior of your colleagues or patients, you're depending on them to change their behavior from their own individual action. So you're kind of, reinforcing that through maybe conferences and grand rounds and flyers around the clinic, and you're hoping that sort of reinforcement will ultimately change the system. A lot of the projects that we work on in quality improvement at least start at this level, because they might be smaller departmental projects that we're sort of testing, how we might be able to improve something, and then you can always scale it up from there. The next level is process design. So that's going to be about 95% reliable. And this level kind of relies on reliability science. So we're thinking about things like decision trees, standardization of processes, redundancy, reinforcement. And then when the process doesn't go according to plan, you know that in real time through real-time failure identification. An example of a process design would be like a reminder that pops up, a best practice reminder in eRecord. It's not a hard stop, but it's there to reinforce that good behavior. Level 3 is 99% reliable. So this is hardwired into the system to the point where it's almost impossible to do the wrong thing. So if you think about outside of healthcare, for example, if your car will not lock if the keys are in it. So that makes it impossible for you to encounter that adverse outcome. You're hardwired against it. And so those system level designs of certain interventions, that it's almost impossible to have the adverse outcome. So now that we've talked a little bit about the impetus for quality improvement in healthcare and some of the background on how it came to be integrated into healthcare, let's talk about value. So over the past decade or so, there's been a lot of talk about value-based care. What does that mean? We're coming from a fee-for-service model where we're focused on volume and moving towards a value-based model. We're going to be looking at what are the outcomes that we're achieving, and when we're achieving the outcomes that we want, how does cost factor into that? Because of course it's not sustainable to achieve positive outcomes if the cost is exorbitant. And so keeping value in mind when you're pursuing process improvement projects and you're thinking about potential initiatives is really going to help kind of make that connection between outcomes and cost. So many of us have probably seen a graph like this. We know that healthcare costs are ever increasing in the United States. We have the most expensive healthcare system in the world. And what many people don't know or may not know is that up to 40% of those dollars are actually waste. And so when we're thinking about talking about value, we don't want to cut the things that work. We don't want to cut the evidence-based medicine, the patient-centered care. We want to cut out the things that are wasteful. And so process improvement will help you diagnose the waste in your workflows and in turn achieve better outcomes at lower cost, which in turn is higher value. So this visual can help us kind of understand the flow of a patient, what happens from when a patient gets treatment to health outcomes, and kind of define what health outcomes are versus processes. So of course, everything in healthcare is going to start with a patient or a population of patients who have a health condition. Then we move over to the processes. This is where Christy and I pretty much spend our time working. Those are protocols, guidelines, current state workflows, the things that happen in your daily work. Then below that, you can see the structure. So that would be the physical space of your workspace, the staff, and the kind of different education that staff have, et cetera. Then we move over. So one distinction that is important to make is that we spend a lot of time talking about improving outcomes, but improving the processes is where you're going to cut out the waste that then indirectly improve the outcomes. Indicators are more of those discrete data points. that are sort of predictive in the health outcomes. They themselves are not the health outcomes, but data points such as hemoglobin A1C. If you have a goal for a certain outcome, those predictors are going to kind of help you move towards that outcome and kind of inform your process changes. So then we have the outcomes themselves, and you'll see this little oval here is patient-reported healthcare outcomes, which is something that's gained a lot of notoriety in the past several years because it's really valuable to hear from the patient themselves. What are their goals of care? What is their experience? And even being able to collect that information when they're not sitting in your exam room is extremely valuable in terms of achieving those positive healthcare outcomes. Then patient satisfaction with the care experience, that kind of goes back to the original triple aim that we talked about, is improving the way that patients perceive their healthcare experience. Now, of course, a patient may have a great experience, but then if we go back to those original 6 aims, if the care wasn't evidence-based, it doesn't really matter if they had a great experience because you're still probably not consistently going to drive towards those positive outcomes. And outcomes can be difficult to define. Christy will talk more about this in her part of the presentation, but when you start thinking about a goal or a problem statement, you're going to want to make sure that you know how to measure those outcomes and that the people on your team are all in agreement about what those outcomes are and how they're going to be measured. For example, you may want to reduce length of stay, but you have to get clear on how you're defining that. Are you talking about hours? Are you talking about days? Does the clock start when the patient walks into the emergency room? Does the clock start when the patient hits the inpatient floor? So those kinds of things are important to define, and communication is really important at that point of kind of defining your problem statement and your goals. So focusing on the value add. So I sort of spoke to this earlier about wanting to diagnose the waste in your processes and rather than eliminating the things that work. So you're going to want to think about what things are adding value, what things are working, because as Dr. Don Berwick said, in relation to this problem, reducing waste is the most affordable and humane and smartest opportunity we have to make an affordable healthcare system. We don't want to reduce the things that are working. We want to really find the things that aren't and overcome them with processes that help achieve the outcomes that we want. So as you start to think about potential projects, you'll want to develop a clear problem statement, like I mentioned, and SMART aims can help you do this. They can help you define your problem and also what your goal might be and how you're going to measure it, because you want to be able to measure your success, because if you don't measure it, you won't know whether you've made an impact. Another kind of popular quote within quality improvement is "Some is not a number, soon is not a time." If you're saying we want to improve this group of patients, experience with X, well, how much and by when? That'll really help to keep you on track in these improvement projects. And here's just a quote from the former COO of Seattle Children's Hospital. "We rarely talk about cost. We talk about waste, quality, and safety, and find that our costs go down." So this is kind of going back to the essence of the triple aim. And this work is not simple. It is not a linear path. Often, it's more of a winding road, and you have to kind of go through these different iterative processes to find out what works and what's going to make an improvement. But focusing on reducing that waste and improving quality and safety will in turn reduce costs. So one thing that's really important to distinguish is what is the difference between project management and process improvement. Both are structured approaches, but you can think of project management more traditionally as a facilitating a process that has a beginning point and an end point, and kind of going through that linear process. Whereas process improvement, like I mentioned, is more kind of organic and cyclical. And you're going to kind of have maybe micro projects within your overall initiative. And sometimes you may test an intervention, find that something doesn't work, and then you're going to want to double back and collect more baseline data. But one thing that I think is also important to mention is that you don't want to get bogged down in those details either. Quality improvement is not the same as clinical research. You don't have to have a validated survey instrument. You don't have to have the equal number of patients in the intervention and control group. You need just enough to know that you're making a difference. And so keeping that in mind is kind of the idea of just start, fail fast, get your group together and create buy-in in the actual problem and the process, and just start testing interventions and see what happens. So project management is an essential part of any process improvement initiative, insofar as you need somebody who's responsible for kind of the logistics of moving the project forward. Because if it's everybody's responsibility, it's nobody's responsibility. And we don't want a good process improvement initiative to fail because of a lack of organization on the side of more of the logistics and the project management. So now we're going to move on to the improvement science frameworks. Christy is going to talk in detail about DMAIC, which is the framework in orange. And these other three are up here because you may have heard of them before, or you may have used them before, but really they're all different means to the same end. They use different language and different breakdown of the steps, but they're all essentially whichever one you are comfortable using and whichever corresponding tools you feel better suit your group and your needs. It's all process and quality improvement. And then you'll see along the bottom here, lean principles, project management, change management. Those things kind of encompass any process improvement project, because like I mentioned, project management is essential, but you're also kind of need a little bit of that change management to drum up interest and buy-in and support for your initiative. So with that, I'm going to hand it over to Christy to talk about DMAIC.
Thank you, Stephanie. All right, so if I were to ask any of you if you have a problem at home or at work, I'm willing to bet that most of you would say there is some opportunity, something that you would like to make better. And so what I'm going to do now is kind of help you figure out how to start. There's these methodologies out there, there's tools available, but often it's hard to know kind of how do you begin and how do you use them. So I'm hoping that over the next half of this talk, I'll be able to share some of those and kind of have them make sense to you. Whether you use PDSA or A3 or the model for improvement or DMAIC, like I'm going to take you through, one of the key concepts is that you start with the problem. Our tendency, our sort of way of thinking is to go with the solution. There's a problem, we want to fix it. So I'm going to try to show you how to slow down, really focus on the problem. The more understanding you have about the problem, the easier and better the solution ideas you have will be to get you to the sustainable, measurable improvement that I know you want. So with that, I'm going to ask all of you just in your heads to think of a problem, not the solution. Think of a problem. It could be big, it could be small, it could be at work, it could be in your personal life. But think about a problem and then hold on to it. And as I go through the various stages, think about what you know, think about who else you might need information from, think about how you know that the problem that you have is an actual problem and how big. So everybody take a moment and think of a problem. All right, everybody got a problem? Usually not a shortage. Okay. So this is the DMAIC framework. This is a Lean Six Sigma methodology, and it stands for Define, Measure, Analyze, Improve, Control. And this is really a roadmap for your process improvement journey. In general, you move through things in order, but as Stephanie mentioned, process improvement is not always linear. So there are times where you will move from one phase to the next and then learn something and have to double back and sort of revise. So that does happen. It's what makes process improvement a little bit messy sometimes. The key though, and the reason that these sort of milestones can help and phases can help is it helps you to make sure that you don't skip a step, that you don't jump too far ahead. So just know that there's a lot of learning, and you have to be open to that learning as you go. We say lots of times in our work, you have to trust the process. It will feel uncomfortable at first, but you must trust the process. Okay, so if you have a problem, problems get identified in lots of ways. It could be from quality and safety events. It could be patient experience surveys. It could be staff feedback or ideas about how to make something better in your work environment. But once you have a problem identified, the first thing you want to do is write it down. You're going to see that many of the tools, and this is not an exhaustive list or presentation on all of the tools that are available, but these are some of the ones that we find most valuable and use most frequently. But you'll find that many of them, their main purpose is really to write it down, validate what you know so that you can share it with other people. And a project charter or scoping document is one of those tools. So if you have a problem, write down what you know. You shouldn't know everything about it at this point. That's why you're going to continue on this journey. But you need something to help gain consensus, get support from sponsors who you may want to support you on this initiative, and get a general idea about what the goals are, who's going to work on it. There's a place on here for your hypotheses so that if you have solution ideas, or you have ideas about what's causing the problem, you can get those out there so you can come back to them. But you need some boundaries about how this work is going to get done and who is going to help you along the way. Process improvement is a team sport. And then once you have some agreement on what you're going to work on, what the reason, your reason for action, and agreement that this is something that is prioritized within your area, there's several tools that you can use. And this is where I'm going to ask you to kind of shift from problem to process. So you have a problem. All the work that we do is a process in some way. So I'm going to walk you through this in just a second to show you that, but everything we do is a process. Scheduling patient appointments is a process. Preparing patients for hospital discharge is a process. Doing a procedure on a patient is a process. It all is a series of steps that happen and have a beginning and an end. So this tool here stands for suppliers, inputs, process, outputs, and customers. And this can be really helpful at the beginning of a project to kind of help, again, validate what you do know about your process and what you don't. So you always start, SIPOCs grow from the middle. So you start with your process. This is a high level view of your problem or your process. But this can help gain clarity around your scope. So where does the process start? Where does your process end? Then you go the other way. What are the inputs or the things that you need to make that process occur? And who are the people that supply that? Then the other way, what are the outcomes that result from your process and who is going to use them? And the reason that this can be helpful to lay out in this way is on those outer edges. I mentioned process improvement is a team sport. On those outer edges, if there's suppliers or customers in your involved in your process, at a minimum, you want to make sure that they're aware that the project that you're working on is occurring. But more likely, you probably need feedback or input from them and might even need them on your team. Your inputs, your outputs, and your process really come into play when you start talking about measures or areas for gaps or barriers. So we'll dive into this a little bit more. We love SIPOCs. We use them all of the time because they can be a good way to kind of, again, get people all together and get some clarity about your process. Okay, so that's defined. So you've got a problem, you've clarified, it's the scope, the people involved, and now you want to move into measure, which is where you're going to document in more detail than was on your SIPOC what is really happening in your current state. So this is a basic process map. This is a great way to gather understanding about what is currently happening. There's other types of process maps as well, but this is a basic one. It just outlines the steps. And you can do a process map in a conference room with a group of people, especially if you have a process that involves a lot of different departments or a lot of different roles. It can be very revealing to use sticky notes, either real paper sticky notes or electronically, and walk through what is happening. It happens on a regular basis that we will hear, oh, I didn't know you did that, or, oh, I didn't know that was why we did that, because you needed that piece of information. So it can be a good way to gain understanding and also promote some teamwork in your project. But one of the best ways to do a process map is to go and directly observe. So sometimes if you have a complicated process, you can gather an initial sketch in a conference room with people, and then you can go and validate it, observe, walk the process yourself, or you can start with that and observe it and bring it back. The key in this phase is to capture what is happening now, not what should be happening or what you want to be happening. You can use this further down in our journey to make a 2B process map or an ideal state process map once you understand where the gaps and barriers are. But at this phase in measure, what we're really just trying to do is understand what is happening now so that then we can use this to analyze in our next phase. So the other way to gather information about your current state is with actual data. So numbers data, rates, volumes, percentages. And there's different types of measures. There's outcome measures, process measures, and balancing measures. And Stephanie showed that picture earlier that kind of got at some of these. But I'm going to try to just break it down just a little bit more. You need this baseline data to validate that the problem that you have is actually a problem and to be able to say how big it is. So that helps you to set achievable goals and can give you a way to measure as time goes on whether an improvement has occurred once you make a change. Okay, so outcome measures are the overall goals. So maybe reduced infection rates is the overall outcome that we are looking for. And maybe hand washing compliance is a process step that contributes to that. So that is something that needs to happen in order to get to the goal that we want. Balancing measures can be intended or unintended. So that could be things like the cost of soap and paper towels and things like that, if in that hand washing example. A more patient-specific example I sometimes use is if you're trying to help your patient get to a target blood pressure, and maybe the intervention is prescribing medication. The outcome is that goal blood pressure. The process measure is how often they actually take the medication that you have prescribed. So if they don't take it, you can't expect that you're going to achieve the outcome that you want. Balancing measures in that example, some you might expect. So you would want to watch out for hypotension in that example, or other side effect monitoring. And as Stephanie said, you don't have to measure everything. We want to try to move quickly. It's important to cover all of these steps, but none of this has to take a long time. So once you've started to gather information about your current state and you get some data, you think about what it is that you're trying to improve, what the outcome would be, what the process measures are. You can gather some of those from your SIPOC. That's how this one is laid out here. You want to put that into a data collection plan. Again, none of these are magic. None of these are very complicated. This is one version of a data collection plan. You could use many others. The point is, it's a document that helps you to gain clarity with yourself as well as the team that you're working on about what your goals are and what the definitions are. So if you were going to be measuring, let's say your outcome measure was readmission rates, this can prompt a lot of discussion with your team. Are you talking about 30-day readmission rates or 90-day readmission rates? Is it for patients readmitted to our hospital or patients readmitted to any hospital? If it's for any hospital, do we have that data? Can we get it? Who can help us achieve that if that's what we're looking for? So this is a way to, again, just write things down, gain some clarity, have a discussion, and use it as a reference to go back to as well. It happens regularly that we'll say, wait, what did we say we were going to measure? Wait, what was the definition of that? So this is just another tool for writing things down. Okay, and smart aims can help. You don't have to gather everything. It can be very tempting to get as much data as you can possibly get your hands on, but you really don't have to. You have to focus. So SMART aims, which stand for, and you'll see some variability in these, but they all get at the same key points: specific, measurable, attainable, relevant, and time-based. Soon is not a number, or some is not a number, soon is not a time. So this can help you. Our objective is to, reduce 30-day readmission rates among COPD patients by the end of the year or by December 31st, something like that. Okay, you can do that for outcome measures. You can do that for some of those sub-projects within if you have process measures that are in here. So we will increase hand washing compliance from 50 to 80% by the end of the year or something like that. And then the relevance there is to improve maybe your infection rates. So if you're finding that you're struggling, try to put a SMART aim together. If you can't put a SMART aim together, you might have skipped ahead. So you need to know what your baseline is. You need to know what your target is so that you know what the gap is. So this can be a good way to kind of, before you move forward, pause and say, do we really know where we are right now? All right, and once you do know where you are, and once you do have your baseline, it's never too late or too early to start a run chart. So as you move along, and I know you're like, when are we going to get to the solutions? Oh my gosh, we want to do something. I promise we're going to get there. But when you get to that point, you're going to want a way to plot along what you're doing and whether or not you're seeing improvement in whatever the measure is of interest. So once you have your baseline data, set up a run chart right from the beginning. I often say to people when we're working on projects, like, what's going to be on your poster? What's going to be in your presentation? What is the thing that you're going to show? How are you going to show people that you went from here to there? And this can be a way, a great way to start that early. So start a run chart as soon as you have your baseline data. This can also be a good way to start to promote buy-in. Data is essential for promoting buy-in. So the earlier you can get a handle on it, the better. Okay. So we've defined our problem. We're looking at it as a process. We've done some measuring of our current state. We have some data. We have some process maps. We've talked to people. Sometimes measuring can be just talking to people and getting the voice of the customer, the people who are doing the work. And then we're going to analyze it. So measure and analyze again. Sometimes there can be a lot of fluidity in this between these two phases. It's hard to get data and not analyze it. But there's a lot of different ways that you can look at your information. So this is a common tool that we use. It's a Pareto chart. And the Pareto principle, or the 80-20 principle, says that 80% of effects come from 20% of the causes. So analyzing data in this way helps you to sort out the vital few from the useful many. So you don't have to fix everything, and probably it's not in your best interest to fix everything. You want to focus on those highest frequency or highest impact problems and come up with solutions for those, and then measure how close to your goal you got. So there's a lot of prioritizing in process improvement. One of my process improvement mentors says that process improvement is like breathing. You expand and you contract. And so that's sort of what we've done thus far, and we continue to do. So there's lots of problems and you prioritize. You measure lots of things and then you prioritize. And you do the same thing when you're in analyze. You're going to find lots of contributing factors. You want to focus on those highest impact root causes. Okay. So we're really getting here. We're getting down to the goal of process improvement here, which is get to your root cause. So if you have a problem, we don't want to band-aid it. We don't want to just treat the symptoms. We want to get to the root cause so that we can solve the problem and not 5 years from now be sitting in a conference room saying, I don't understand. How come we have to keep solving the same problem? So this is a way that you can use the information that you've gotten in the prior two phases to get at that root cause. It's a very simple exercise called the 5 whys exercise. And really all you do is you say, here's our problem. Why is it happening? Okay, why is that happening? So an example I can give you was a project I worked on with a team here at Strong, and they had noticed that they had an increase in their staff injuries. And when they looked at the data from the injuries, they noticed that almost all of them were occurring during patient lifting and repositioning. And when they looked a little deeper, they noted that staff were not using the assistive equipment that was available to them on the unit. So it could have been very easy to say, we are going to just re-educate everybody, right? That's often one of the first things is, we're just going to put it together in in-service and tell everybody that they need to do this. But this group really was used to doing this type of work and said, no, we're going to really try to understand this a little bit better. So they surveyed their staff and asked about their use of assistive equipment for repositioning and lifting. And when people were not using the equipment, they asked why. And so what they found, there were several reasons, but one of the key reasons was that the equipment wasn't readily available at the time that they needed it. So then they asked why. And it was because they need the equipment in the patient room, and the equipment was kept in the storage room. So why? Well, because that's where it had a space to live and could be charged, because these were pieces of equipment that needed to be charged. So why? Really, it was that was the norm, and there wasn't really another good reason why, right? So they said, well, what's this? If the problem that we're getting at is that our equipment is too far away from us and it doesn't have to live there, what can we do to address that? And so they worked with the facilities department and they built folders on their vital signs machines that live in each of the patient rooms so that the equipment was readily available at the time that the nurses and techs needed it. And then they resurveyed their staff. They've done this several times now to get information about use of the equipment, and they monitored their staff injuries. And they found that their compliance went up and their injuries went down. Again, if they had just treated the symptom, they probably would not have gotten down to that root cause. So 5 whys can be a really easy but very powerful tool. Another way, and you can incorporate the 5 ways into this, but this is a common tool that people have seen for process improvement. It's a fishbone diagram, or it's called an Ishikawa or cause and effect diagram. And as I said, sometimes there can be multiple different contributing factors to your problem. So if you're looking at your data, you're looking at your problem, if you have from your Pareto chart, you take the biggest bar in your Pareto, you put it at the head of the fish there, and then you say, you know, this is the problem, why? The headers on here, you can adjust those to match whatever makes sense for your project, though you're not stuck with those main headers. But then within those categories, you can outline what the more granular reasons are. And you can start on that first, I don't know if you can see under process where it says first why. You can do the 5 whys exercise there, get at your root cause, which is circled in red there, and then you can lay them all out. And it can be a really powerful way for people to see not only the root causes, but also all of the contributing factors. And then you have to, again, prioritize. You probably aren't going to work on everything all at once, but what are the key things that are contributing to your problem? Okay, we're getting there. We're finally to improve. So again, this expanding, contracting. So we get to our root causes, and then this is where people always want to start right at the beginning. We get to brainstorm some solution ideas. So the key here is brainstorm solution ideas that address the root cause that you've identified. And then you can put them on a list. You can put them on a matrix like this one, which is called a benefit effort matrix. And you can use this to prioritize. How hard will it be to do it, and how high of an impact, if we did that solution, would it have on solving our problem? And again, this is just a way to visualize, keep your team together, and promote some discussion about how to move forward. I will say that sometimes what you end up in that the quick wins, which is your high benefit, low effort, things that you think are easy sometimes end up not being easy. So just be prepared for that. But again, that's all part of the learning of process improvement. All right, so you did it. We've gotten through define, measure, analyze. We've brainstormed some ideas, and now it's time to do something. Finally, it's time to do something. And this is where you can use a 2B process map to help clarify what the change is going to be. This is where piloting is going to occur. So you're going to do some experiments now. You're going to test your solutions, and you're going to monitor the impact that it has on the measure that you're trying to improve. I would encourage you when you pilot, to start small. You can do something with 1 patient for 1 day. Did a project over at Sawgrass a few years ago. There was a lot of concern about whether it was like going to break everything. And so we did it with 5 patients on 1 morning, and it didn't break everything. It actually worked beautifully. So then we were able to gather some momentum and do it for a full day, and then do it for a full team. And finally, then it was able to be spread. So start small, learn with each pilot that you do. So this is where PDSA cycles come in. So you're going to do some planning, you're going to pilot, and then you're going to see what you need to do differently. Sometimes it doesn't work. Sometimes it is a disaster. Sometimes that's why if you do a small pilot and it really doesn't work, great, didn't break everything. You abandon it and you try something else. More often, maybe it was close, but not perfect. You adapt and then you move forward. Stephanie mentioned project management. I'm going to include change management here as well. This is the phase where some of the other some other methodologies and tools and skills can really come into play. That would be a whole nother talk. But project management, change management are key in this phase as you're trying to make change. Change can be very, very challenging sometimes. So having an organized approach, having good communication, and keeping everybody aware of what you're trying to achieve is super important here. Okay. And then again, kind of summarizing, documenting, this is another tool, one of our favorites. It's called an A3. An A3 is the size of a large piece of paper. Here we use just a regular 8.5 by 11 piece of paper, and we have it on we have this information on two sides, but this is really how you can tell your story, your process improvement journey. Much of this you capture from your project charter, and then you validate it as you go along, but this is a living document. You update it as you go. And so what I would ask here is the problem that you all started with, that you had in your mind as you've gone through, how much of this could you fill in now? And how much of it do you need more information to be able to do? So if your problem, you would put that in your reason for action. Do you have the value outlined clearly? Is it something that other people would get behind? And can you communicate that to them? Do you have a baseline or a measure already available to you? Sometimes you do, sometimes you don't. Do you know what your target would be? Is it realistic? Is it something that other people, again, can get behind? And do you know what your root cause is, or do you need other people to help you figure out what that would be? That box 11, countermeasures, those are solution ideas. That's another way of saying solution ideas to address the root causes. The second page there is your results and for your PDSA cycling, so that you can, as you do experiments, you can document it. Sometimes people will either drop in a run chart there or add it as a second page or third page. But this is just a way to tell your story, keep track of things, and be able to communicate it to other people. But you really want to make sure, again, that those measures are tight, because that is one big way you're going to gather buy-in. And then the last phase, which is sometimes the most neglected, because people are so excited that they've finally been able to do something and we've seen some success, but your work is not done. If you want to avoid that, didn't we already solve this a few years ago dilemma, I strongly encourage you to pay attention to this phase, which is the control phase or the sustainment phase. This is where when you find something that has worked, that has had a measurable improvement, you want to hardwire it as much as you can, and you want to make it the new way. And you do that through things like standard operating procedures, or developing training for new staff as they come on, for clarifying roles and expectations, and figuring out how you're going to monitor the measure that you identified as time goes on, so that you know if you're going off course. Things are always changing. That is the only constant. Things are always changing. So something that works now might get impacted further down the road by something that we just haven't even thought of yet. So keeping your eye on the measure that matters can be a way to make sure that things don't get totally out of control at some point in the future without you realizing it. This is also a time for reflection with your team, your project team. What went well? What could have gone better? Can improvements be considered by other areas? What will you do differently on your next process improvement journey from everything that you've learned on this one? So to sort of wrap up, process improvement isn't magic. It is work. It takes discipline, but there are lots of tools out there to help you. One of the biggest things is start with the problem, not the solution, and keep an open mind. You don't know sometimes what you don't know. So trust the process and stay open to that. Data really does help to promote clarity and buy-in when you can show how bad a problem is or how big of a problem it is at the very beginning, and then that your improvement is or isn't making a difference. That can really help guide how you continue to progress through your journey. You have to have sponsors and stakeholders engaged most of the time. Unless this is a process that only you are accountable for and have sole control over, you're going to need other people involved. And as I said, there's usually more problems than we have time to solve. So there has to be some prioritization and some agreement about what you're going to focus on when. And change can be hard. The slide that Stephanie showed at the beginning, sometimes, we get into a routine and life is busy and work is hard, and the idea of doing something different can be really daunting. But there can be great rewards at the end. So with that, I will say it can be a winding path, but it can be very, very rewarding. I encourage you to celebrate when you have success at the end. And also along the way, it doesn't have to take a long time, but it often takes longer than people want. So celebrate often at each phase or at each win to keep the momentum going. And I wish you good luck on your future journeys. I guess with that, I can open it up for any questions or comments.
Hi, thank you so much. This is a just incredible array of tools and perspective that I think has so much potential value for our organization. We did a project down in the operating room over the last couple of years as it related to a particular material, disposable, and I thought that it was able to incorporate stakeholders very readily, and we were able to make the change in a relatively smooth manner. And that's in and of itself is I think quite remarkable. But since that change occurred, we're sort of in the, for lack of a better word, the control space now. There really isn't incentive to sustain that change, and so. I cannot, if you will, blame, the users for going back to the previous way, because, there isn't proper incentive to stay in this one, particular decision. So I guess I'm just fascinated to know how, from a systems point of view, we can sustain some of those well-defined changes, short of, penalties, short of money, for lack of a better word. So any ideas or insights would be welcome.
So I think that kind of goes back to the reliability. You're depending on people to do the individual action because they know it's the right thing. And so thinking about ways where you can get close to like hardwiring that solution, whether it's, I think you mentioned it was a disposable supply. So whether only if in terms of purchasing what you're buying, what alternatives you're offering, if you're asking for the supply to be reprocessed, making that reprocessing readily available so that it's easier for people to do the right thing than it is the wrong thing. That's hard to do, but those are my initial thoughts.
Yeah, definitely making it easy to do the right thing is always a way to go. I guess I would also ask at the beginning of the project, what was the value that was identified for it, and who was sponsoring or championing the initiative? Because sometimes I think if that isn't strong and clear from the very beginning, you kind of end up in this place where, it relies on the energy of the people that were involved. So maybe an idea might be to think about what the sort of value proposition is, and engage a champion maybe who can help to put this on the radar and share it and talk about it. I think sometimes just really just keeping things front of mind for people and making a routine, this is something that we're watching, this is something that we're looking at, can go a far way without having to get into penalties and things like that, which we always try to avoid. Yeah. Thank you.
That's a wonderful talk, and it's very important to emphasize. You guys are only a few of you, and I'm sure your department isn't very big. So how do we have some mentorship and some training that we can create more staff that can help you or help us in our department to make this happen here?
Yeah, That's an awesome question. I'm so glad you asked it. So if you work here at the medical center and you're looking for some more information about this, there is a MyPath course. So as far as training and education, there is a MyPath course that you can watch and learn more. There is more and more of this being incorporated into residency training here at the Med Center. So that is sort of helping to bring some of this along. But I would say for us, we really do need, this happens often, like I say all the time, like we're not magic. I wish we were. It would make our jobs a lot easier if we actually had a magic wand, but we don't. So what we need from departments and from divisions is what are the things that matter to you? What are the things that you are looking at? Is it volume? Is it revenue? Is it throughput? Is it patient wait times? Is it, there's usually categories within these different areas. There's quality and safety concerns. Stephanie mentioned them when she showed the aims, right? You care about a lot of different things. There's going to be, quality and safety. There's going to be efficiency things. There's going to be revenue. And so what are the categories that you're looking at, watching and caring about that then sort of set the frame for that prioritization and work going forward? So keeping an eye on those things that do matter and aligning them with whether it's hospital strategy or a clinic area, I think that that's a really good first step to kind of launching you and keeping some focus, and actually can help then avoid some of the people working on things that then maybe aren't the priority and can fall off. Thank you.
A question, yeah. So a couple of things I observe, especially with busy clinicians, there's a couple stumbling blocks. One, they often can identify the problem, but they can't get started in this process. Or if they do get started in the process, the next stumbling block is implementation. They don't want to put that energy into to make their life easier. I don't know what to do about that or how to help, but any suggestion? Does that resonate with you, or does that,
Absolutely.
Yeah, I think that that's obviously a huge barrier is, just time. Everybody's busy, everybody has full schedules. And so I think a way to kind of overcome that is similar to what Christy said, is to prioritize what are your most urgent problems and work on those, because it can and get some quick wins under your belt to motivate people. Because if you're working on something that isn't affecting your daily work, it's not making your workday better, it's going to be hard to keep with it if it feels, more theoretical and way down the line. So if you can really work on the things that are most important to your group and you can see some change quickly, I think that is a way to make the team realize that, this is impactful work and kind of just keep the engagement going.
I'm good. So how do other departments bring this into their culture? Is it individuals that are doing it on their own? Is it divisions? Is it an entire department that needs to say, here's our priorities for the entire department? And how do you see that playing out in most other groups?
I think when it works best, there has to be support for it from the top down in the organization. Because like we talked about with sort of the levels of reliability, if you're working on something in just a small group, you might be able to make change, but ultimately like sustaining that and spreading it is going to be difficult if you don't have that sponsorship like Christy was talking about, and the champion of your project who can kind of oversee it for the long term. I don't know if you have anything you want to add.
No, I think for the problems that we're often encountering are not small. So there has to be, a sponsorship from the top. I think there can be value in small individual projects as long as they're well supported. And then you kind of meet in the middle a little bit, but everybody is busy right now. And I think there's a risk to sort of the grassroots approach, because then you run the risk of people starting things that they can't maintain. And that can actually be more damaging than not, because then people get discouraged. So,
and to your point too about time and bandwidth to take on these projects, if they are supported from, chairs, supervisors, whomever, then is, I think, empowering to people to continue the work because they have the support from their colleagues too.
So the question, David Meeker, how do we identify as a faculty what to do? I think that's what we're working.
No, I mean, we are working on that actually. And we're trying to come up with the best plan, but you know, when we came 4 years ago, we changed the organization to try to create a service chief based approach with associate chairs rolling up to the chair. And while we did that and we supported the chiefs and the chairs in their endeavors, we haven't really defined things very well. So I don't think I've done a very good job of working with each associate chair and service chief and creating definitions of what this actually means. Was kind of all done grassroots. Now I feel like we've stabilized our organization at least a little bit from the crazy growth we've been through. And I've had more time to just, ponder more strategic type thinking and talking with me through about this. And so that's a goal, to really look at the organizational structure and create definitions and sitting with each one of the leaders to define their role and that to give them objectives to carry out. And we're hoping that will create more direction. And then they can, then you can get buy-in from certain pools and certain leaders in the organization to carry out whatever plan you're trying to improve. Mithra, I don't know if you have another take on it.
Yeah, the ability to harvest the talent and to develop the talent, I think is going to be one of the great challenges over the next phase of the Flaum Institute, and creating an organizational structure that has pipelines, not sort of notions bubbling up to leadership to make decisions, but stable pipelines where that sort of experience on the ground level is identified and recognized at decision-making points, and then making those decisions fast and again, failing fast, as well as learning from that. I think there's a ton of opportunity from a design perspective to harvest the talent.
One of the first questions that Stephanie and I will ask departments or teams is, what's your governance structure? If you're, who is supporting this? How are decisions made? And so when we get to the point of needing to make choices about things, is it this group that has ownership over that decision, or does it need to go to somebody else? And sometimes just asking that question can open up a bit of a Pandora's box because it isn't always perfectly clear. But you can't empower people to do something if they don't know where else they need to go or who they need decisions from. So I guess that's another sort of a structural thing that we asked that right at the beginning, because without it, you can stumble.
One of the issues and one of the issues is when you keep improving, I know David's always trying to get more efficient. But it's like, what's the benefit to the average technician or clinician or whatever? It's almost like, system can create very, very efficient systems. And you see that in some corporations, but the humans in the system sort of ground down into the ground. So how do you balance this efficiency issue with human? What's in it for me, kind of? If I'm a technician and I need to be more efficient, but I have to work harder, and I'm not seeing benefit to me personally. I just feel like cognitive machine. How do you deal with it? Right.
Yeah.
Yeah, I think that's a great point. And I like how you said the what's in it for me, because that's what we ask a lot when we're talking to groups about the projects that they want to do and how to kind of make that change and sustain it. It's, it's different from a traditional manufacturing industry where so much of what we do in healthcare, it's people and it's managing behaviors and encouraging behavior change. And that's really hard to do. And it's hard to compel people to want to do that. And so I think finding, and, maybe it's through something like the 5 whys, finding what's in it for me, and working on the things that resonate with people, and maybe, leaving some of the other things for another time and seeing, if they come up again after down the path of different initiatives.
Let's look at a question in the chat. Rachel, what are your thoughts on applying these processing tools for problems that are a bit more difficult to find, and more personal nature, wellness, engagement?
That's a great question. And things that are not seemingly super defined can be kind of challenging to address. But I would say that within all of those things, there's ways to measure. So figure out what a weighted measure would be. So wellness, maybe there's questions on the staff engagement surveys. And culture of continuous improvement is something that we talk about a lot with groups. And so what would that mean? What would that look like? It's generally not how many projects you've checked off in a given year. That's usually not the measure that you're going to go after, but it could be things like how comfortable are you in using certain methodology, or how have you been involved, or do you want to be involved in a process improvement initiative? And would you feel, what do you feel your confidence level is in being able to do that? Or what are the barriers that are preventing you from wanting to do that? So there's lots of information, I think, sometimes out there. And so picking through and trying to identify what you have available to you. There's a great question on the Press Ganey is, will the information from this survey be used for improvement? Which is one that sometimes I look at to kind of get a sense of how a department is kind of gauging on that culture scale. So I would say find a way as you can to figure out how you will know. It's again getting those measures. How will you know? How big the problem is, or if you're making it better as time goes on.
I think all of these topics too, wellness, engagement, and culture, they seem like great opportunities to craft a smart in too.